And thank you very much for attending today our webinar that's on the response evaluation criteria in cancer immunotherapy. I am Dano, Chief Operating Officer at Median Technologies, and we are pleased today to cover this topic as part of our webinar series. So as you might know, Median Technologies is expert in oncology, and about 50% of our trials are related to immuno-oncology. Now, we reckon that we can be lost with the different immune-related criteria. We have several, such as IRRC, IR-resist, I-resist, IRANO, and others for specific indications. So we have invited two very knowledgeable radiologists working here at Median Technologies who will help us to better understand this imaging criteria. So we will have with us Dr. Yen Liu. Dr. Liu has been with Median Technologies for the last 2 years, and she's our Chief Medical Officer. She's expert in imaging biomarkers for clinical trials, and prior to joining Median Technologies, Dr. Liu was head of translational research at EORTC. We have also Dr. Antoine Iannessi. Dr. Iannessi is radiologist. He recently joined Median Technologies. He's also an expert in oncology imaging and artificial intelligence and computer science. So both Dr. Liu and Dr. Iannessi have authored and co-authored many publications in the field of imaging in oncology. So we will start the presentation just before starting. Two main points. First, we would like this webinar to be interactive. So you may ask questions in writing. You should have something on your right to be able, so you can write questions, and Dr. Liu and Dr. Iannessi will answer them at the end of the presentation. And we will start now first with a first round of questions for you. So we have only 4 questions, which will help our panelists to target the presentation. So if we can have yes, the questions are displayed. So this is the first question that we have here. So please click on the correct answers for you. You may have several answers that might apply. So should the immune modified criteria be used in trials of anti-cancer immunotherapy trials? Yes, for primary endpoint. Yes, for secondary endpoint. Yes, only for exploratory endpoint. No, not at all, or you do not know. We will now soon look at the answers. Okay, if you can click. Okay. Okay, so thank you very much. So we can see that 1/3 of the audience here do not know, while 1/3 believe this is yes for secondary endpoint, and we have a few with primary endpoint or exploratory endpoint. So we will cover that later on. Second question. What is the added value of those immune modified criteria? So a very good question here, and you may have several answers. So is it to better capture response, better capture time to progression, surrogate beta associated with overall survival, no difference compared to RECIST 1.1, or you do not know? Please click on the ones you believe are relevant. And once that's done, we will switch to the answers as well. So it's kind of, we had several answers in many occasions here. So better capture response, better capture time to progression. Yes, well, all of us know that, which is very good, that there is a difference compared to RECIST 1.1, obviously. So we will cover that as well. Third question now. What should we do if it is a double-blinded study? Should immune-modified criteria be used for control arm as well? So several answers might apply as well for all arms, for all patients, for all arms. If patients are clinically stable, only be applied after unblinding the arm of immunotherapy, or you do not know. A few seconds to click on the answers. And for 2/3 of us, this is for all arms, for all patients, and then we have a split between for all arms if patients are clinically stable or only applied after unblinding. Okay. And we now have the fourth and last question. So there is no right or wrong answer for this question. It's just to help us to better understand what you have done yourself. There are so many immune modified criteria. So which one, please tell us, you have already used? Have you worked already with the criteria IRRC, IR resist or IM resist, I resist, LYRIC, or iRANO? And we can see that, hey, many of you have worked with the last criteria, which was published in 2017, I resist, while some others have worked a lot also with I resist or IM resist and IRC as well. Okay, well, thank you very much. So thank you all for your participation. We will now begin the presentation. So we will start with Dr. Liu. Dr. Liu, this is now up to you to start the presentation.
Thanks, Nico, for the introduction. And for today's webinar, I will first share with you the story why immune-modified criteria were developed, and followed by an overview of immune-modified criteria. And hereafter, my colleague, Dr. Iannessi, will give you more examples on the difficulties and challenges of imaging reading in immunotherapy, and what added value that medium technologies could provide. So, lesson learned. Mobilizing tumor immune system against the tumor is not a new concept. It dates back to at least the middle 19th centuries. A German pathologist, Dr. Virchow, observed immune infiltration in tumor. However, the clinical development of several immune therapy approaches has not experienced great success at the beginning, such as cyclotron treatment or vaccine, aiming at stimulating T-cell immune response. They were introduced to trials, but with limited success. The turning point for immune therapy came with so-called immune checkpoints, owing to the understanding that T-cell response are regulated through on and off switches. The CTLA-4 was found to be one of the most important switches for T-cell activation, and following the regular approval of ipilimumab, a CTLA-4 inhibitor, in 2011, the field of cancer immunotherapy has started its renaissance. The remarkable improvement in patient survival with immune checkpoints are now also changing the standard of care of oncology. The use of PD-1 and PD-L1 inhibitors has become the standard of care approach for many patients in many cancers. And meanwhile, the success of immune checkpoints also extended to other modalities, such as CAR T cells, which are already showing attractive clinical trial results and got regulatory approval. Overall, this trait will have tremendous impact on the future oncologic treatment landscape. As we know, the traditional trial design might not be suitable for new treatments. Methodological errors such as selecting non-representative population and inappropriate criteria may also potentially prevent the development of a promising drug. A good example is the clinical development of ipilimumab. The initial study endpoint were overall response rate and progression-free survival. Early trial results were not encouraging, as low conventional response rate, about 5 to 15%. Fortunately, the Cancer Immune Consortium evaluated its results based on immunotherapy mechanism and clinical observation with ipilimumab. Adaptive criteria were also proposed. The overall effective rate increased to approximately 30% when measuring delayed response, prolonged stable disease, and also the response in presence of new lesion. Most importantly, favorable survival data were also observed and associated with new pattern of response. And following the promising phase 2 study, a positive phase 3 study trial were also reported in patients with metastatic melanoma, which demonstrates a hazard ratio for survival of 0.66, with a reduction of deaths by 34%. Ipilimumab was subsequently approved by the FDA in March 2011. In parallel to that, the development of ipilimumab may be not a lucky one. Ipilimumab had similar clinical features and safety profile as ipilimumab, and when it was investigated in advanced melanoma, a response rate also about 10%. The dosing escalation of ipilimumab trial was only one treatment every 3 months, which is much less compared to that of ipilimumab, one treatment every 3 weeks. Knowing that the median time to progression was around 2 months in metastatic melanoma at that time, the majority of the patients in the trial stopped the treatment before the second dose. Ultimately, ipilimumab and Pirmaturay in phase 3 following the evaluation by a data monitoring committee, who recommended stopping the study based on the early interim analysis. And later on, a moderate separation curve of survival with a hazard ratio 0.88 reported at follow-up year 2. The modest long-term survival benefit could be a result of underdosing of patients with a single dose of ipilimumab. Despite this suspension of clinical development, AstraZeneca has reintroduced ipilimumab into trials as combination therapy. But up to date, ipilimumab has not been approved for single use. So you could see the different outcome of two similar drugs, but due to different design. So we can see that the early lessons of immune checkpoint inhibitors and measuring efficacy or measuring safety are widely recognized by stakeholders for immunotherapy drug development. And also, following the recommendation of the Cancer Immune Consortium, the US FDA and the EMA also released guidelines. The classic response pattern of traditional chemotherapy is tumor shrinkage after treatment. However, cancer immunotherapy showed different response patterns. Considering the response patterns of immunotherapy, such as durable stable disease, response after initial disease progression, simultaneous response in baseline lesion and presence of new lesion, and new immune-related response criteria, IRRC, were published in 2009. So now I will present to you the key immune-modified criteria and with examples. Here you can see this is the family tree of response criteria, which showed you the whole evolution. The WHO criteria established in 1981 was the earliest to standardize response assessment for anti-cancer treatment. In 2009, an updated version of RECIST 1.1 were published. To date, RECIST 1.1 is the most widely accepted criteria for response evaluation in tumor with the exception of brain tumor and lymphoma. In 2009, IRC were introduced, as we just explained it. And 4 years later, in 2013, an immune-related response criteria in solid tumor, IR-RECIST, were proposed, with combined IRC and RECIST 1.1 by using unidimensional measurements and the confirmation of progression. Despite those immune-specific response criteria, many immunotherapy trials still use RECIST 1.1 alone and combined with various versions of modified criteria, which therefore make a universal comparison of data very difficult. The RECIST working group, together with FDA and EMA representatives, published a consensus guideline, iRECIST, that describes a standard approach to measure solid tumor response to cancer immunotherapy. It also recommends that primary outcomes such as objective response rate, progression-free survival should use RECIST 1.1 for pivotal trials, while using iRECIST for exploratory endpoints. Immune criteria for progression confirmation should only be applied when a patient is clinically stable. And in 2018, Dr. Rodi and colleagues also published IMRECIST. It is a refined guideline to assess clinical benefit of cancer immunotherapy. The IMRECIST is very similar to IRRECIST, but more detailed in terms of new lesion measurability and number of new lesions that could be selected as new target lesions. So there was many immune-modified criteria. What is the difference in terms of outcome using those immune-specific criteria? This is RECIST 1.1. Do they better capture response? Is it associated with overall survival benefits? Dr. Rodi and colleagues investigated the value of IMRECIST based on atezolizumab data. They found minor difference in best object response rate with a 1 to 2% increase using IMRECIST. The disease control rate was 8 to 13% higher with IMRECIST than with RECIST 1.1 alone, which was largely driven by a higher stable disease rate. And consistently, you can see immune-modified progression-free survival, so IMPFS, based on IMRECIST, was 0.5 to 1.5 months longer than PFS based on RECIST 1.1. And how about the association with overall survival? So the study also evaluated the difference when we compare IMPFS versus PFS associated with overall survival in the atezolizumab trial. Among all patients, approximately 1/3 of them were alive and had RECIST 1.1 progressive disease within 90 days of involvement. In the BIRD trial and POPULAR trial, which have both long cohorts, the median overall survival was 4 months and 1.4 months longer in patients with PD based on RECIST 1.1 compared to PD based on both criteria. But however, there was no difference seen in the RUTIL-0 cohort. So in this table, you can see it shows difference among RECIST 1.1, IRRC, IMRECIST, iRECIST. No worries about too much information, as we will also provide you the difference. So you can see here, the IRRC requires the biodimension measurements. And IMRECIST, iRECIST, as RECIST 1.1, measure unidimension. IMRECIST has been tested with retrospective data of atezolizumab trial, while iRECIST was based on consensus agreement. And also for iRECIST, new terminology were introduced, including immune complete response, iCR, immune stable disease, ISD, immune partial response, IPR, immune unconfirmed progressive disease, IUPD, and immune confirmed progressive disease, ICPD. The difference between IMRECIST and iRECIST are two main points. In IM RECIST, non-target lesions contribute to defining CR only, but no impact on PD. And the new lesions are incorporated into tumor burden, while for iRECIST, non-target lesion and equivocal progression will also trigger IUPD and ICPD, and new lesion will be measured separately and not incorporated into the sum of measurements. And then we will also give you some examples. You can see an example compare RECIST 1.1 with IM RECIST. The baseline SOD, so the sum of diameter, is 130. And despite the decrease of target lesion SOD, new lesions appear as TP1. Therefore, it triggers PD for RECIST 1.1. While it still remains SD, where we incorporate new lesion into tumor burden. Another example, the same thing, the baseline SOD is 130. And we can see non-target lesion and equivocal progression lead to overall response for RECIST 1.1 PD, while it still remains SD for IM RECIST because non-target lesion progression has no impact on IM RECIST progression. The third example to compare RECIST 1.1 with iRECIST. So the first PD of RECIST 1.1 will be iRECIST IUPD. In this case, the new lesion disappeared at the TP2, so PD was not confirmed. And compared to the baseline, the TP2 overall assessment is IPR. So we have seen a lot of cases in solid tumor. And how about lymphoma? The Lugano certification established in 2014, which provide important proliferation and modification of the DG-PET and diagnosis CT interpretation, but does not specify its role in immunotherapy. And in 2016, the lymphoma response to immunotherapy, the LIRIC, was proposed by the International Working Group as a provisional modification of Lugano adaptation for immunotherapy. A new response category terms indeterminate response, IR, were introduced, which provided flexibility to allow patients to continue treatment past IR with a confirmation evaluation within 12 weeks. So a patient will be considered as IR when he or she meets one or more of the three conditions. 1, increase in overall tumor burden in the first 12 weeks of therapy without clinical worsening. 2, appearance of new lesion or growth of one or more existing lesion, but lack of overall progression, meaning less than 50% increase of overall tumor burden. 3, increase in FDG uptake of one or more lesion, but without a concomitant increase in tumor size or number. And you can see also a biopsy is encouraged in the situation 1 and 2 to distinguish the real progression from pseudo progression. Also, in patients with IR, it is also required to repeat image to confirm progression. How about brain tumor? For glioblastoma, a panel of immuno-oncology experts also proposed a guideline, iRENO, for the determination of brain tumor progression in patients undergoing immunotherapy. The key component of iRENO is the confirmation of radiological progression combined with clinical status to decrease the likelihood of prematurely declining PD in patients with pseudoprogression or delayed response. This panel also recommends that among patients with early progressive imaging findings, including new lesion, but clinically stable, meaning no experience of significant neurological declines, and those patients will undergo immunotherapy for less than 6 months. So in this case, a confirmation of radiological progression should be done 3 months after. And the new enhanced lesions outside the mean radiation zone will not automatically denote progressive disease. They will be added into tumor burden for the follow-up assessment, and also for the follow-up imaging confirmation of progression. If it's confirmed, then the date of active progression will be back to the initial date. So thank you for my part. And then I will introduce my colleague, Dr. Iannessi, will share with you more examples on the challenging cases. And so Antoine, the floor is yours.
Thank you, Ian. Thank you, Dr. Liu, for this introduction. After you describe these different immune criteria, we'll in fact go by detailing the pitfalls and challenges in interpretation of the follow-up images during immunotherapy. And then for my second part, I will also try to explain the expected benefit from a centralized review. So the major risk in assessing immunotherapy using imaging is the misclassification of the response. This may be caused by two classes of pitfalls. The first one is an intercurrent event visible on the images that can be related to an immune adverse event, for example, but also a simple modification of the immune system, and especially the lymph node enlargement that we will see on the next few slides. The second reason for misclassification can be linked to the special type of response compared to what is observed with cytotoxic therapies. So there are also some site-specific response patterns, not specific from the immune criteria, but difficult to assess, and I will go through the bone metastases, which is especially challenging to assess for such type of patients. Unfortunately, these difficulties of assessment can lead to a discontinuation of a potential effective therapy. And in the literature, Dr. Tezat showed that in 2018, around 5% of discrepancy between the RECIST and iRECIST criteria. And 10% of the patients claimed to be progressive using the RECIST criteria were actually underestimated benefits. So that showed the importance to really try not to fall in these pitfalls. The first reason for misclassification with immunotherapy follow-up is the atypical type of response. Early in 2009, Dr. Volchok had already identified that around 15% of patients experience some immunotherapy specific atypical type of responses. In this study, 3 types of response patterns were identified in addition to the normal shrinkage of the baseline lesion. So the first type of specific pattern of response was a smaller shrinkage of the lesion and a more delayed but also more durable response. So this was the first type of atypical type of response. So this is not really a problem when you use the criteria which are standard, but there were also 2 other types of atypical type of response called pseudo-progression, because actually they simulate a type of early progression. One of this profile is a response after an initial disease progression, like in this case. And the second type is also called a dissociated response, and it's a simultaneous response in the baseline lesion and the appearance of a new lesion. So these 2 types of pattern are absolutely not captured using the RECIST 1.1. Also, keep in mind that in this study, this type of pattern were representing only 10% of the patient. So that means that 90% of early progression is actually a real progression. Moreover, and more recently, a so-called hyperprogressor profile has been identified in certain patients who will worsen very rapidly and will require treatment to be stopped. Overall, there are two concepts to remember to understand the foundation of immune criteria. First is that a new lesion doesn't mean a progression, as it has been shown when we were explaining the criteria. And the second one is the progression always needs to be confirmed. Based on these two foundation principles, there can be some adjustment between the criteria, especially the way you will consider a new lesion. And for the time of progression, for example, it can be different considering the type of criteria you will use. What is also important to understand is that on site, such equivocal progression situation might trigger a biopsy. So when we speak about central review, the result of such biopsy is really precious for the evaluation. And we will see later that this information can be given to the readers for central review. So I would like to show an example of atypical response from the literature. This patient was treated for metastatic adenocarcinoma by an immune checkpoint inhibitor. And as you can see, initially the baseline targets decrease and they will disappear until the end of the follow-up. However, at 24th week, a new equivocal lymph node appears and it's subsequently confirmed as a new lesion using a biopsy. So in this case, you have a typical type of dissociated response, which is more often seen using immunotherapy. And then for the same patient, after an adverse event, hepatitis actually, the treatment had to be stopped. And the disease progressed extremely rapidly within one cycle only. So this type of progression is also called hyperprogression. The second reason that can lead to misclassify the assessment during the imaging follow-up of patients who undergo immune therapy is linked to the toxicity. Indeed, autoimmune reaction can be observed to the disruption of the cell tolerance, and it can lead to a wide range of adverse events. Depending on the checkpoint inhibitor, there have been described different patterns. Maybe keep in mind that for CTLA-4, it's more the colitis, while for PD-L1, it's more the pneumonia. Anyways, these adverse events can be clinical, biological, but also radiological, and that's that makes difficult the assessment sometimes because there is really many radiological manifestations related to them, and the radiologist has really to be aware not to misclassify them as new lesions. Moreover, it has been shown that it's very important not to confuse them with the progression of the disease, because the same patient who suffer from the side effects are also the more responsive to the treatment. The gastrointestinal toxicity is maybe one of the most reported toxicity. It's recognized and can be easy, like in this case when there is an enteritis and the digestive tract is thickened in a diffuse way. But it can be also sometimes very difficult to differentiate from a new lesion, like in this pseudonodular colitis. So it really can be challenging to make the difference between one adverse event and new lesion. The second most reported toxicity is the respiratory toxicity. And in the same way, some lung disorder can mask or mimic a progression. Most of the time, they are easy to recognize. But in this case, it's not the difficulty to make the difference between an adverse event and a new lesion. It's more the difficulty to assess what there is behind this adverse event, which is making a problem on the assessment. Moreover, and this case is a good illustration, some of these adverse events can occur really late. So it's sometimes really difficult to think that it's an adverse event because we are late in the treatment, but actually, and it's the case for this patient, you can see that this pneumonitis occurs 10 months after the introduction of the immunotherapy, and after the treatment has been stopped, we can see that the patient immediately got released. from this pneumonitis. So I would like to insist really in these immune-related adverse events and concerning the efficacy of the centralized review. It's really important to get information regarding these side events because they impact the radiological assessment. So usually reviewers are trained to alert the medical lead in case of potentially serious side effect. But specifically for immunotherapy, it's really important to ask them to comment on any abnormalities which is not directly related to the evolution of the disease, because this information will be really precious when we have to adjudicate and to evaluate the efficacy of the treatment. There is not only adverse events, it can be also just a modification of the immune system. And the most frequent syndrome that is observed is the sarcoid-like mediastinal syndrome. It's basically an enlargement of the lymph node inside of the mediastin, like this, like you can see here. And it can be really difficult to say just using images that this is not a progression. Most of these patients are symptomatic, but on site, this type of situation most of the time is solved using biopsy. That's again a reason that we have to really find a solution to get this information of biopsy when we want to have a centralized review. Finally, the bone metastases are challenging for immune criteria, but they are also for RECIST criteria. Like I can show in this case, there is some paradoxical reaction, which is called osteoblastic flare. And at the baseline, you don't have lesion, but on the 12th week, you have actually a new lesion appearing inside of this vertebra. It's a blastic lesion. And some readers could say that this is a new lesion, but it's not. It's an healing process of the bone. So it should not be confused by and saying that this is a progression. This is really typical, but it can be quite confusing when we assess immunotherapy, because this type of events are observed more often. And then once this is said, would like to enlighten the reason why centralized reading make the assessment more robust in this case. So what can you expect from a centralized review with respect to the on-site reading? It's the whole process of trying to guarantee a good assessment. First, we have to make sure to recruit experts, and if necessary, as you can imagine, we need to recruit a multidisciplinary team, because some criteria, they also include some clinical insight. Okay. Once they are, this team is recruited, we try to train them. And because there is not yet complete consensus on these criteria, most of the time they can be adapted according to the study. That's why it's really important to train the readers for these specific adaptations. And there, the monitoring for immunotherapy is really important, because the discrepancy rate between readers and the adjudication is the really KPI that we have to follow. And because of these challenging cases and pitfalls, it's in this case very important to share them between the readers in order to improve the assessments during the ongoing studies. As we have previously explained, the assessment needs some clinical information, and I'm speaking here about the biopsy. This information are really important to target the lesion, but also to assess the progression. And through a dedicated platform, I see we have the possibility to export the information from the iCRO in order that the reader can know where he can target or not the lesion for the baseline, and he also have to, this information can be shared, especially the radiotherapy, to be sure that no lesion will be taken in the previous zone of radiotherapy. Because of the immune criteria, there's something interesting that we can do. We basically can derivate the immune criteria from the traditional RECIST criteria. So for our way of working is that we ask the reader to do one imaging review, and from this only one imaging review, we can derivate it actually two types of endpoints. So the one which is RECIST 1.1 and one or more immune criteria. So this is really a way to diminish the error, because the intervention, the human intervention, is done only on the image review, and based on the RECIST 1.1, we will derivate the immune criteria. We also have a way to let's say decrease the error, and for that we use EdiCheck in order to avoid deviation from the criterion. As I explained before, because there are some different criteria, it really can be adapted, and the readers really can maybe make more error because of this adaptation. So it's important to check if the number of lesions are exactly the one that we need, if some lesions have been missing during the evaluation, and also because these cases can be equivocal when there is progression. We always ask to provide mandatory comments for every progression. So this said, we can conclude. And we can conclude by saying that immunotherapy is distinct from traditional chemotherapy, and especially in terms of tumor response pattern. For this reason, there is a clear need to refine the response criteria. iRECIST is a consensus statement, but it still needs some prospective validation. As we've seen on the pool question, this is obviously the criteria that most of you are using, but keep in mind that it will still need some prospective validation. What about the progression? So let's say that the treatment beyond the first progression may help a well-defined subset of patients, but these patients have to be clinically stable. 90% of the early progression are actually real progression. And the last message is, if you had to choose, so the current state of the art requires RECIST 1.1 as a primary endpoint. But it's true that on the literature and the iRECIST paper, for early stages, iRECIST might be used also as a primary endpoint. However, concerning late stages, I would not say that immune modified criteria should be selected as a primary endpoint, but more as a secondary or exploratory endpoint. I think I have finished for my part, so now maybe we can go, everyone, guys, online, and go on for question and answer if there are some questions from the attendees.
Thank you, Antoine. Exact. Now we're entering the Q&A session. I would suggest just give a couple of seconds for the questions coming in. And please submit your questions regarding the presentation or anything that you have when you use RECIST or immune modified criteria. Okay, great. I got a couple of questions. So question one, IRRC, iRECIST, IRRECIST, IMRECIST, which one should be chosen? Good question. So as we just said that indeed there are a lot of criteria. Either they are based on small sample size, retrospective studies, or consensus agreement. So those are not studies has been criteria has been validated by large cohort. As suggested by RECIST working group, the immune modified criteria is better to be used as exploratory, and in very few exceptions, it could be used as co-primary endpoint. And also now the IRRC, because it used bidimensional, and it is less and less used in clinical trials. So the most frequent use is IMRECIST and also iRECIST. As IMRECIST is published in 2018, so it's the most recent one, and it's also tested with the retrospective data, and also has been associated with overall survival benefits. And iRECIST is recommended by the RECIST working group and also regulatory representatives. So in both publications, it mentioned that further validation is still needed with large cohort or prospective trials. So I would say if you will choose to use immune-modified criteria, immune-specific criteria, then both RM resist and I resist could be the choice. Okay, okay, let's see other questions. Okay, so since you mentioned that, could we use I resist to convert resist outcome? So theoretically, yes, because the I resist, so the first resist PD is the IUPD for I resist. But however, we have never been required to do so, to convert primary endpoint from exploratory endpoint. But, yeah. Other questions? Can you FDA acceptance for your experience? So currently, the FDA, they are more suggest to use immune modified criteria as so exploratory endpoint. So as also when we see the pseudo progression rate is different in different solid tumor. So like for lung cancer is less, but for melanoma it's more. So it also depends on the disease type. So this is what we see with regulatories. Yeah.
Yeah, I have one question that I can answer maybe from my side. It's concerned the adverse events. So given the confounding factors with immune-related adverse events, would you ever support including these events to the independent reviewer so that they can factor this into their evaluation and not prematurely select PD? So yeah, that was exactly the message here, that we absolutely want to at least have the feedback from the reviewer. So that's why for this evaluation, it's really important not to have both the evaluation of the disease, like we do, like RECIST 1.1, but also some more insights for non-directly related anomalies. So that's the point with the comments. Yeah.
Yeah. I also get one question. Could you please provide your recommendation on the quiz 3 question? I resist on double-blinded study for control arm. That's a very, very good question. Actually, it is also quite depends on the study design. Since for some studies, if it is double-blinded, and the study design will also indicate that they maybe have unblindness, and after that, the investigator may perform differently. So based on which randomization the patient has been, which arm the patient has been in. But in terms of central reading, we do not have more information about the patient treatment in which arm. So in this case, that we will only perform the reading according to the images that we receive. So we will perform to all arms. And indeed, there was also an analysis depending on so how the immunotherapy has been used and also the roles has been defined. So it will be also integrated in your study design, also in the protocol. Yeah.
Yeah. I have one question here. So the question is, can you please a little elaborate the usage of iRECIST, and is there a specific version available? And the last point was, are you using it in current clinical trial setups? So as we said, iRECIST is a consensus, so all is based on the paper that you can find. The last version is from 2017. So I mean, I don't know if you have some point to add, Jan, but yeah.
Okay. Yeah. I have another question is, please clarify why IM resist are only used for secondary or exploratory endpoint in late-stage trials. I think here is also what we're saying is the recommendation by the RECIST working group. Since all the immune-specific criteria at the moment needs to be validated. So RECIST 1.1 is still the main criteria will be used for confirmatory trials, for pivotal trials. So in this case, I think it's the stage of the trial. It's the phase and also the importance of the trial, whether it's used for a confirmatory. And in this case, it's better to use RECIST 1.1 for primary. Any other questions? Are you aware of any immunotherapy that has been regulatory approved? And so what is imaging assessment used? I think there was many immunotherapy has been approved by regulatory. That is the first paper we showed. And I will say that many of them also based on the traditional RECIST 1.1 criteria. And there was also could have the submissions with both data sets, so using modified as exploratory to combine this as a supplementary information. Yeah. So good. I have a question for you here. I received Antoine. Is this so when we mentioned the lymph nodes, so the circuit-like pattern you have described is only in the mediastinal location or other locations?
No, any location can be enlarged. So, and this is probably the most reported, but any enlargement can be actually not really linked to progression. That's the point, and that's why the biopsy sometimes is needed, because you cannot be sure 100% that this is a progression. It can be just a granular inflammative disease. So it can be, we can't say that this is limited to a mediastinal reaction. Can really be seen everywhere, abdominal, inguinal, axillary. So yeah, no, unfortunately not.
Mm-hmm. I have another question. I maybe missed something, but how do you get results for both RECIST 1.1 and iRECIST with one read? So do you want to answer that, Antoine, or you want to?
Can you? I did not really. Can you repeat, Jan?
So how do you get results for both RECIST 1.1 and iRECIST with one read?
Yeah. Again, this is possible only because this type of criteria are derivated from the original criteria, which is RECIST 1.1. So if you pay attention to the way you do your imaging review, and speaking about the way you look at the images, you will anyways take target, anyways take non-target lesion. So that's the way we deal with that. The difference is how you you manage the confirmation. So then we have implemented some specificities inside of IC that makes us makes the possibility to get the endpoint different, but the evaluation on the same image, the evaluation on the image, give you two type of endpoints. That's what we want. What we don't want is like to ask the radiologist to do two different evaluation. So that's, and it's possible only because these criteria are historically linked to the standard criteria, like RANO and iRANO, RECIST and iRECIST. So that's the reason. Yeah.
Okay. Yeah.
Okay, I think we are done with the questions. So thank you, Dr. Liu. Thank you, Dr. Iannessi. In one of the questions that has been asked, someone asked if iRECIST was used by Median Technologies. Yes, we use it on a regular basis. 50% of our trials are on immuno-oncology, and most of them, not all, but most of these 50% are using iRECIST because this is a pretty standard criteria in immunotherapy. So I'd like to thank once again Dr. Iannessi, Dr. Liu, and all of you who attended this webinar. Thank you very much. You will receive a link of the webinar by email, and you can also look at our website because you will it will be available on the website, which is www.mediantechnology.com. You can also follow us on LinkedIn and Twitter if you want to have more information about what we will be doing in the future in terms of webinar or offer. So bye-bye. We are looking forward to seeing you in our next webinar. Thank you very much. Bye-bye now.
Bye. Thank you.
Bye.
Thank you.
Thank you.